Okay, welcome back.
Sorry, that's my bad.
Got it? Okay, I was echoing there for a second. Welcome back, everyone. And I know we got to hear a lot this morning, right? Does everybody feel like there is a lot going on in this space? Yes. So I am so grateful again to hear all of our federal agencies. We got introductions around the table from our non-federal members and our federal members. I want to switch it up a little bit on you because we have a distinguished member. He is a member of the council, the past council, and the only returning member, I believe. I'm going to read his bio to you, and then he's going to do a presentation because what we wanted to do was leave some space in the conversation, and I want you all to know, I want to rest assured members, we are going to get time for dialogue and conversation because we are not going to leave this building today, I promise you. It's a long meeting. It's our first meeting as new members. It's the first meeting of the year, so there's a lot to digest, a lot of good work that we needed to hear from all of the infrastructure and spaces. So wanted to get that done, make sure we get, and then we got our ethics training, so all good things. But I wanted to leave space for innovation. And when I use the word innovation, it's just a generic term for anything novel, innovative, out of the ordinary in our usual conversations about Alzheimer's and related dementia. And I thought it would be really neat, we thought it would be really, really neat to start with our returning member, Dr. Randy Bateman. Just listening to him talk, the first time I got to talk to him on the phone, it's not just what you're going to hear, the science of him, but the heart and passion that he brings to this is just infectious. I am so grateful and honored to be serving with a clinician and a scientist like Dr. Randy Bateman. So I'm just going to read you his bio very quickly. Dr. Randy Bateman is the Charles F. and Joanne Knight Distinguished Professor of Neurology, Director of the Dominantly Inherited Alzheimer's Network, or DIAN, Director of the DIAN Trials Unit, DIAN 2, Principal Investigator of the Bateman Lab, and Director of the Tracy Family Stable Isotope Labeling Quantitation Center for Neurodegenerative Biology. That is a mouthful. Dr. Bateman's research focuses on the pathophysiology and development of improved diagnostics and treatments of Alzheimer's disease. Dr. Bateman treats patients with dementia at the Memory Diagnostic Center of Washington University. Dr. Bateman is a productive innovator with 47 active or pending patents, has established multiple research consortiums, and established the Silk Center to further advance in neurodegeneration and aging by utilizing precise measures of neurodegenerative proteins and their production, transport, and clearance in health and disease. He's been a member of the Advisory Council since 2021. Please join me in welcoming Dr. Randy Bateman.
Thank you for, thank you for the very kind and gracious welcome back. It's good to be back here and with a new crew. I'm really looking forward to the next 4 years and what we're going to accomplish. I wanted to take the opportunity to share some good news of what's happened over the past 10 years and to point to what I think is likely to happen over the next 4 years of our service in Napa. And so I'm going to cover 3 major domains. One is going to be on Alzheimer's disease and diagnostic testing and where we're at in terms of blood tests and simple diagnostic tests. I'm going to focus on what's coming next, and I think that's going to be how we can substantially stop this disease through prevention. And I'm going to end on a forward-looking statement and vision of how I think the latest generation of artificial intelligence will transform everything we do in science and medicine. I want to start with a base foundation here. What is the challenge? What is Alzheimer's disease? Most of us are very familiar with Alzheimer's disease. We've worked with it very closely over many years, decades. And still today, we don't have a definitive way to absolutely stop the disease. We have made progress. We've made progress in being able to deliver some of the first disease-modifying treatments that change the course of Alzheimer's disease for the first time in human history. We've made other progress, but there are still fundamental things we don't understand about this disease. And these fundamental things are clues. One of the biggest risk factors for Alzheimer's disease is aging itself. And I believe that some of the things that drive Alzheimer's disease is the aging process of the human brain. And so that if we really want to understand the fundamental risk that causes Alzheimer's disease and other age-related neurodegenerations, we need to begin to understand the aging process in the human brain. Alzheimer's disease has been known for over 100 years. During this time, as I said, we've recently been making breakthroughs, but for a long time, there was little progress being made. It wasn't until the 70s when it was realized that Alzheimer's disease was a common disease of aging people. And then in the 1980s, when the first proteins of the Alzheimer's pathology were described in amyloid plaques and tau tangles. The 1990s brought about genetic insights that led to the molecular biological revolution that led to the ability to develop treatments targeting these pathologies. And then it would take another 20 years of development from those discoveries to lead to some of the first treatments that could actually halt and reverse the pathology of Alzheimer's disease that would subsequently lead to the clinical evidence and proof that we could change the course of this disease. The NIH has supported research over many decades in Alzheimer's disease, and one of these research studies is the Dominantly Inherited Alzheimer's Network shown here. You can see the red and blue pins throughout North and South America, Europe, Asia, and Australia. These are medical centers working on Alzheimer's disease, studying a very rare form of Alzheimer's called dominantly inherited Alzheimer's. This is a familial disease. A mutation in the family causes disease in about half the family members, and they get it at a very young age, in their 30s, 40s, and 50s typically. They dement and die like people with Alzheimer's do, but tragically at a very high prevalence within that family. It does offer the opportunity, however, to study the disease in an exquisite way because we can predict when they will get sick. We can monitor how it changes over time. And I don't know if yeah, there we go. The years are counting up, and you see on the left-hand side, these are amyloid plaques on a PET scan. And on the top, the counter is going down to the year of first symptom onset. And so right when we reach 0, the first symptoms begin. And what you'll notice as that plays through again, you will see that starting 20 years before the first amyloid plaques begin to develop in the brains of these people. So that's on the left and on the top. And notice as the ticker goes on, the amyloid plaques slowly and steadily build up, but no changes in metabolism or atrophy in the middle and the bottom right until about 5 to 7 years before symptoms. And right at symptom onset, right now, the amyloid plaques are fully established and other processes are taking on. We now know that those other processes include tau tangles, cell death, and neuron loss. Using this information that was discovered through public research, scientists discovered biomolecular signatures that allowed us to track the plaques, not just in PET scans and cerebrospinal fluid, but now in blood. And so here's some data from my lab showing that the phosphorylation of tau at 217 correlates very closely with the development of amyloid plaques. And so now a single blood test has accuracies upwards of 90 to 95% accurate for identifying amyloid plaques, and that's shown on the right-hand side. More recent developments have discovered different kinds of biomarkers. This is tau microtubule binding region 243. That's a mouthful. We use these complex terms and numbers to refer very specifically to the exact atoms and molecules that change in Alzheimer's disease that we can now detect in blood. So tau tangles, which previously were only measurable through PET scans and at the time of death, we can now track with a single blood test, again with very high accuracies of about 90% in a blood test. So how are these scientific advances that we're making in biomarkers, clinical treatments, how are we applying them right now in the clinics for our patients, and how are they likely to be applied in the future including treatment, but also prevention. So shown here are some reports showing highly accurate Alzheimer's disease blood tests are clinically available now. These reports demonstrate that compared to the standard CSF and PET scans, these blood tests can be just as accurate, if not more accurate in some comparisons. And they can be used in primary care clinics, even beyond the specialty clinics like mine that we typically are involved in. The specialty clinics are using these tests more and more. Shown here, dating back to 2021, is our clinic at Washington University in St. Louis. And you can see in blue, we pretty much only did cerebrospinal fluid diagnostic testing, and at a fairly low amount. So most people in 2021 did not have the benefit of accurate biomarker-informed diagnostic testing. In 2022, as blood tests became available in the clinic, you see in red the blood tests were taken up by the clinic. And then in 2023, with the advent of treatments, where we had a strong reason to accurately diagnose people before putting them on treatments, you can see the number of tests, both CSF and blood tests, dramatically increased. And then with coverage of amyloid PET scans, shown in gray in 2024, you can see those tests increasing. So in the clinics over the past few years, we have changed how the practice of medicine about how we diagnose patients. A specialty clinic like ours might get 70 to 80%, some of the best ratings in the world. Primary care physicians are about 50% accurate. And these tests can drive us to over 90% accuracy. This is a transformative change that has occurred in the clinic. What does this mean for how we treat people and how we follow people over time? Shown here are the results of several trials of anti-amyloid drugs, showing that those that reduce the amount of amyloid plaques rapidly to near normal are the ones that have clinical benefit demonstrated in their phase 3 clinical trials. These disease-modifying treatments change the course. You see the two lines separating it out over time, and so people who are on placebo don't do as well as people who are treated with these anti-amyloid drugs in a clinical progression scale that matters to patients, family members, and their caring doctors. The translation from Alzheimer's disease treatment to prevention trials may be coming very soon. In fact, it may be within the next few years. A precursor or a sentinel study may be these families who have the mutations. Back in 2012, with the support of the National Institute on Aging, we launched the first Alzheimer's disease prevention trial in dominantly inherited Alzheimer's disease family members. At that time, we did not know which treatment was going to be most effective. We did not know if it would work. We launched with 2 different drug programs that went on, and after the results of that initial trial were read out in 2019, we switched to the one that was lowering amyloid plaques and normalizing some of the biomarkers, an antibody called gantenerumab, which removes amyloid plaques. That study was extended for another 2 to 3 years in an open label extension, and I'm going to tell you a little bit about that study now. And these individuals who were treated for nearly 10 years over the time period, who were destined to get Alzheimer's disease, and those who were treated the longest, the people who started on gantenerumab from the beginning, who had no symptoms at the time, and continued on that trial, our latest readout of that drug as we ended it was that they would have approximately a 50% reduction in their risk of having an onset of symptoms of dementia. So half of the people who were expected to go on to have the onset of dementia did not, compared to controls. That means the world to these people who are otherwise destined to have the disease. And here is a report of the actual findings of that trial. This report is the direct readout of the statistical analysis plan. And when you analyze that magnitude of effect, the question that people have is 50% sounds impressive, good, but what does that mean for an individual? And when you model it out, what it could mean is that these individuals could have 5 to 15 years of dementia-free life. And that's something an individual patient and family can understand, that that is important to them. And then the question is this going to predict something like what we could see for sporadic Alzheimer's disease? And to help answer this question, we've continued the study in what's called the Diane-2 amyloid removal trial, because we've switched from using the previous gantenerumab, which is no longer in development, to lecanemab, which is approved. And we're continuing to treat these individuals and follow them because they're now all at that age of onset when they should be having dementia, but many do not. And so we're going to continue this study for at least another 5 years to determine how long and what is the magnitude of effect that these people will have over time. So the trial launched in 2024. We're in the first year. It's fully enrolled. These people continue on the study. Recently, there was a CBS morning special on one of these individuals who ended up, due to the success so far and not having dementia, they actually decided to have a child. They were that optimistic about the future. And so it is changing these people's lives in a substantial way. And I just want to point out that in medicine, we will periodically have major breakthroughs in our approach of what we can do for our patients. And some 30 years ago, people who had hypercholesterolemia, due to a familial mutation, might die of a heart attack or stroke in their 30s, 40s, or 50s. My uncle was one of those individuals. He died at 33 of a massive heart attack. My other uncle, his younger brother, has been on anti-amyloid treatments for an extended period of time and is now a retired lawyer in his 70s because they were able to lower the cholesterol in these individuals. And shown on this slide on the top, you can see the cholesterol deposits in these individuals even in their 30s. And if we treat them with strong cholesterol-lowering medications, they can be prevented from having heart attacks and strokes. And similarly, if we can lower the amyloid loads, prevent the tauopathy, or treat the tauopathy, we may be able to prevent Alzheimer's disease in this population of people with these mutations, but also potentially for the rest of us. So how will we solve this fundamental problem of how aging, brain aging itself, causes Alzheimer's and other neurodegenerative problems? To that end, we believe we can leverage some of the latest scientific advancements of artificial intelligence to make breakthroughs that otherwise would be difficult, if not impossible. And one of the recent organizations that we and other stakeholders have formed is called the Consortia for Biomedical Research and Artificial Intelligence in Neurodegeneration. Cleverly, we coined the term C-brain, so that it would be easier to say than the full title. Shown here is a QR code to the website, and what we're trying to solve is the challenge we're having that we're generating petabytes of data, incredibly complex biological information that's not feasible or possible for humans to fully understand. And so we're going to augment our approach by adding to the approach that we're taking AI systems that can comprehend that much data and can decipher it in a way to lead to biological insights about what is it about the aging brain that leads to these neurodegenerative diseases. What can we do to help prevent, slow down, or stop the disease? And so today, the way we currently do it is it takes several decades to train researchers like us. There are too few of us, and there's too much knowledge to handle. And so the breakthrough of generative AI, deep neural nets, and the capability of learning and understanding information promises to help us pass this huge energy barrier that we face. We need to engage the biomedical research scientists that are the experts and leaders in the world in this field, bring them together with the AI researchers who know how to build these systems and implement them in effective ways, and establish and grow a consortium of us that allows us to lead forward on how to make breakthroughs in our fundamental understanding of brain aging and neurodegeneration. To this end, the members are shown on this slide in this table, and you can see it's a group of academic biomedical researchers, AI researchers, Pharma and biotech has come forward and joined with contributions of data sets and support, and major support from our philanthropic members. So with that, I will wrap up and just encourage everybody, if you're interested in this initiative, please join us at the website, cbrain.org, shown here on the QR code, and indicate that this process of NAPA, of bringing together the information, bringing together the federal agencies, the other stakeholders who are all together in the fight against Alzheimer's, that it's this process that helps us lead to success, that has led to some of the foundational changes over the past 10 years, and that promises to continue to do so over the next 10 years. So I want to again just recognize this moment in history where we've made such incredible progress against this disease, and hope to point to the future with a promise that we will continue this advancement until we can end the disease. Thank you.
Thank you, Dr. Bateman. I'm still absorbing, so thank you so much. I'm sure all of you are too. We have time for 1 or 2 questions for Dr. Bateman. He may have left us all speechless.
Just not a question, but Randy, that was a great presentation and an example, an inspirational one of the kind of science that's being supported. But just another dimension of the project, Randy, if you don't mind my sharing. The Diane Consortium, as you saw, is made up of participants, families of affected individuals who have an autosomally dominant disease. Every year at annual meetings, AIC, these families come together from all over the world. And I share this because one of the most emotional experiences that I've had is participating there, seeing those families, some of whom have decided they want to know whether they carry the gene or not, whether their children will carry or not, to see them interacting in the most profound and respectful way with investigators. If anyone needs more inspiration and hope, it's by exposure to that kind of meeting. So, Randy, I congratulate not just on the science, but in the incredibly inspiring partnership that you've had with the populations who are participating in this research.
Okay, thank you.
I couldn't agree more. Thank you, sir. I'm going to hand it back to Maria because we're going to pivot back to the federal agencies who are going to give us their updates.
Thank you, Michelle. We are going to kick things off with Aaron Long and ACL.
Am I doing something wrong? Which one am I supposed to click? I'm clicking them all. Maybe I'm going the wrong. Oh, you know what? Maybe I did. Maybe that. Sorry. That's okay. Sometimes I get sleepy. Magic touch. Okay. I'm super excited to be here and tell you about all the good work that we've been doing at the Administration for Community Living. The first thing I want to do, though, is I suspect that some folks aren't familiar with the Administration for Community Living. The Administration for Community Living is one of the operating divisions within the U.S. Department of Health and Human Services. We were founded in 2012 when they brought together aging and disability. Our founding principle is that people with disabilities and older adults should be able to live where they choose, with the people that they choose, and participate in their communities. I work within, and all of our Alzheimer's programs that we have are run out of the Administration on Aging. The Administration on Aging is established under the Older Americans Act, which was actually passed in 1965 along with Medicare, Medicaid, and it was the act was founded with the Medicare and Medicaid, and actually it's reauthorized every 5 years. The last time it was reauthorized was in 2020. And what the Older Americans Act does is authorizes a wide range of programs and services that help older adults to age in place. You probably don't know, but it's your Meals on Wheels, it's home delivered meals, it's all those home and community-based services, the congregate meals, nutrition. We have something called the Nutrition Services Incentive Program. We have someone mentioned the National Family Caregiver Support Program. All of our tribal programs, we call it Title VI. There's long-term care ombudsmen, those folks that help in the nursing homes, and the elder abuse, neglect, and exploitation programs. I did want to give you just a sort of snapshot of the aging network. That's what we call all of the entities that we fund and that deliver Older Americans Act authorized services. And I mean, I'm not going to go through it all, but it's those state units on aging. It is tribal organizations. It's those area agencies. Different places call it different things. Some call it councils on aging. It just depends on where you are, what your state, how your state sets it up. But it serves, we're basically helping up as much as 14.6 million seniors, so 1 in 6 seniors, to remain in their homes through low-cost community-based services. One of the data points that always astounds me is that for every $1 the government puts in, we get $3 back in between the services that when bringing volunteers and so for the folks that look for ROI, Older Americans Act, serious ROI. We at the bottom of the pyramid there, you would see if it wasn't so small, you would see that we serve 250 million meals each year, or we have served 250 million meals. 3.3 million hours of case management, 23.8 million hours of personal care and other services, and 7.1 million hours of respite. And I would just say that those numbers aren't necessarily all people living with dementia, but there is a vein of dementia through every single service that the Older Americans Act funds. So the programs that we have in terms of Alzheimer's disease, we've been providing Alzheimer's related programs since 1992. It started with states, and over the years it's evolved. Most recently in 2018, our programs evolved to be called the Alzheimer's Disease Program Initiative. But just our core program requirements are to improve and expand strength-based, person-centered care for people living with dementia and their caregivers, support paid and unpaid caregivers through the provision of education, training, and tools, delivery of dementia-specific, evidence-based, and evidence-informed interventions to support people with dementia and their caregivers to remain in their communities. And through all of our programs also, we have very robust evaluation requirements so that we can demonstrate the impact of our programs, which is a really hard thing to do with any program. We do have multiple variables or multiple programs in our suite of programs. At the core of our program of ADPI is our state, community, and tribal grants, and they are designed essentially we've targeted 3 audiences. We let the communities identify the needs, but our community grantees are targeting supporting people living alone with dementia. We have a significant portion of our programs are focused on or our work is on people with intellectual and developmental disabilities and dementia, and then also just supporting caregivers, providing consultations and behavioral training in the behavioral symptom management. So that's our core program. We also are sponsors of the National Alzheimer's and Dementia Resource Center. So when you get the slides, if you haven't visited our resource center in the past, I like to think it's good. One of the unique things that we do there is when our grantees create good stuff, we put it on there so that everybody can benefit from it. So whether it's innovative programs, tools, training, just papers they've written, they're all housed on. We have a wonderful webinar series that we reach about 10,000 people just in terms of registration for those webinars on a variety of topics that are identified by the communities and are supported by the work that we fund. Those webinars are also hosted by the Resource Center. A couple years ago, we started funding dementia-specific respite programs that is actually funded through the Alzheimer's Association, and it's $5 million a year. 80% of that money goes to sub-grants to get community-based organizations to create innovative interventions to support people remaining in their communities and create models of respite that are translatable and can be scaled up. We also support the Alzheimer's Association's National Call Center. We give them $2 million a year. And this year, everybody is very aware that there's workforce challenges out there. So this year we funded a new program that was just funded in September of 2025, and that's our Developing Dementia-Capable Community Health Workers and infusing them into the Aging Network. So we're excited about that. We're really new into it, but we're very optimistic on what will come of that work. Just so that you can get a sense of where our programs have touched, this is just a map of the different states. Everything that's in blue are the states that we've funded since 2014, and then there's a list on the side of the different types of organizations that we have funded in terms of area agencies, universities, disability service providers, just a very broad range of providers that can have an impact in keeping people in their homes and communities, but also the little icons that are throughout show that we are creating resources and services that are culturally competent and designed to meet people where they are, whether it's African Americans, rural populations, people with intellectual and developmental disabilities. We're really doing our best for the communities to identify the need, and then we help them create resources to support. This is just a snapshot of our NADRC webpage. That's where there's over 300 resources that are located there. So we've been doing this work for a very long time, but last year we commissioned a paper to sort of demonstrate the impact of our programs, and so our contractor was able to do a survey of all of our all of our previous grantees, and then realizing that what they realized with the research was that 98% of our grantees sustain some or all of the activities that we funded. 85% of those sustained activities are actually still being delivered 1 to 8 years later. 70% of the grantees expanded one or more of the activities, so they built upon what we funded them to start, we're very proud of that. When they start these programs, they start with sustainability at the front, so that and that drives their evaluation criteria, so that they have the data to go to the outside of their federal funding. We don't fund things over and over. So we give it to them, and then they need to find other ways to fund it, so that we help them get the data, and they're funding sustaining their activities through philanthropy, state funds, other Older Americans Act programs, and then just their organizational budgets. But that paper also is located on the NADRC website. This is just a plug for, we have a webinar this week, actually, and it's going to have some experts on IDD and dementia, intellectual and developmental disabilities in dementia, and it's on increasing the need for dementia care and support with people with intellectual and developmental disabilities in dementia, and they're going to talk about our successes in serving that population. So there's a link there on how to register it. We also have one coming up soon on food insecurity and people living with dementia, one on homelessness and housing insecure people with dementia, and then bridging healthcare and social services for people living with dementia. So now I'm just going to go through the next few slides are going to talk about some other caregiving programs that we have at ACL and provide a little insight into the number of our ongoing initiatives. But keep in mind that this is like only scratching the surface. Much of what we do at ACL is connecting to caregivers. So we're home to the national strategy for caregivers. In 2018, the Recognize, Assist, Include, Support, Engage Act, the RAISE Act, became law, and it directed for the development of a national family caregiving strategy. In 2022, the first strategy to support family caregivers was created and delivered. They're actually in the process now of updating that strategy, but just a snapshot of that is there's two councils. There's the RAISE Council, and then there's the Supporting Grandparents Raising Grandchildren Council, and both of those councils are working toward achieving the 5 goals, which include increasing awareness and outreach on caregiving, advancing partnership and engagements in caregiving, strengthening services and supports, ensuring financial and workplace security, and expanding data, research, and evidence-based practices. ACL is leading the implementation of the national strategy to support family caregivers, and it's being updated. Another component of that national strategy is our state implementation grant program, and that is essentially state units providing resources to state units to develop, test, and scale models that implement commitments and recommendations that were included in the national strategies. So far, they're cross-fertilizing departments, caregiving across the lifespan, supporting grand families and kinship focus, elevating caregiver issues to governors and state legislatures, and developing disabilities interventions. There are actually presently 9 states that are funded. They've had 2 rounds of funding for that. Another long-term program that we have at ACL is the Lifespan Respite Program, and they basically are supporting the coordinated state systems providing planned and emergency respite care for family caregivers across the lifespan. And as I noted before, people living with dementia and their caregivers they would be a part of the eligible community for benefiting from those grants, from those programs. A number of years back, we created the Community Care Corps, which is focused on training and getting interventions for volunteers. The Oasis Institute has partnered with US Aging Caregiver Action Network and Alterum to foster the development of innovative local programs that provide volunteer, non-medical assistance to family caregivers, older adults, and individuals with disabilities, helping them maintain their independence in their communities. They have, over the course of that program, they have funded in 41 states and U.S. territories, serving 47,000 people with 16,000 volunteers, providing 439,739 hours of service, estimated at a value of $14.25 million. Another one of our central programs is our person-centered trauma-informed supportive services for Holocaust survivors program. This program is improving the national capacity to deliver person-centered trauma-informed services to Holocaust survivors and older adults with histories of trauma and their caregivers. And we've definitely, my font is too small, so I can't see the numbers. But since this has been in place since 2015, this is another one of those programs that is, we give a money to the grantee, and then they do sub-grants to other organizations to get services into the communities. And this one has evolved over time to really be focused on that person-centered, trauma-informed care. And with that, I'm finished.
Thank you so much, Erin, and I have a fondness for ACL, so thank you so much. It's a small but mighty agency doing incredible work as one of the state units on aging. Just thank you for all the support and everything you do for us.
Thank you. We love Florida, too.
All right, now we will turn things over to Dr. Joan Weiss with HRSA.
Thank you. That was great. Okay. Hi, everyone. I'm Joan Weiss. I'm the acting director in the Division of Medicine and Dentistry at the Health Resources and Services Administration. And I'm going to give you an update today on our geriatrics programs. But first, I'm going to tell you a little bit about HRSA and a little bit about our bureau, and then get into our geriatrics programs. So the Health Resources and Services Administration's vision is healthy communities, healthy people. And our mission is to improve health outcomes through access to quality services, a skilled health workforce, that's our area, and innovative high-value programs. And the goal is to support and empower existing healthcare systems, helping communities serve their own people with long-term, cost-effective outcomes. So if you look at the title, 2 words should stick out: resources and services. So part of the agency is focused on providing services to communities. Programs I'm sure you probably heard of: federally qualified health centers, federally qualified health center lookalikes, community health centers, Ryan White programs. So these are our services side. But you need resources to get the services out. So the Bureau of Health Workforce, where I work, is the resources piece. We train the workforce. We are focused on workforce development. So just a little aside. Now, these are our strategies for success. So we recruit individuals from the communities that we serve. We train them in rural and underserved communities. We enhance training for better health outcomes, and we distribute the workforce through our loan and scholarship programs and through our National Health Service Corps loan repayment programs. HRSA's workforce aims are to increase access to care. We want to make it easy for people to get the care that they need in their communities when they need it. We want to increase supply. We want to increase the number of healthcare providers and clinicians, and balance that supply of health workers with demand, getting them, distributing them to rural, underserved, tribal communities and other communities that do not have an oversupply of providers. And quality, we want to improve the quality of the health workforce and the care that they provide. So this slide, we switched our focus quite a few years ago from hospital-based training to community-based training. So we want to train, educate and train students in the pipeline at the undergraduate and graduate level and get them into service into these underserved rural and tribal populations. So now I'm going to talk about our Geriatrics Workforce Enhancement Program, which we call GWEP. The purpose of this program is to educate and train the healthcare and supportive care workforces to care for older adults. And by supportive care workforces, we mean the direct care workers, patients, families, and caregivers. We want to maximize patient and family engagement to address care gaps and improve health outcomes for older adults by integrating geriatrics and primary care and other specialties using the age-friendly health systems framework, which is what matters to the individual. It's 4 M's, what matters to the individual: medications, mentation, and mobility. So these are the objectives of the program. Develop reciprocal partners between academia, primary care, site and delivery systems, and community-based organizations. So, like, you're probably saying, what are reciprocal partnerships? So reciprocal partnerships are when all the partners know what the other ones are doing. So, for instance, we would have primary care practices send someone to a community-based organization, maybe to our colleagues in the administration and community living for Meals on Wheels, and then we would never know, like, did they get the service? Did they go? Didn't they go? So we set up these trainings so primary care would know what community-based organizations are doing, academia would know how to train both sets of partners, and it works really great because now when primary care sends patients for community-based services, they have that feedback loop. And what we found out is some patients take the service if it's covered under insurance. Others may pay out of pocket depending on how expensive it is, and yet a third group won't take it because it's too expensive. And that was really valuable information for us. So we want to transform clinical training environments into integrated geriatrics and primary care sites and delivery systems that are age-friendly and dementia-friendly. Provide interprofessional geriatrics clinical and didactic training. This is a statutory requirement. So all our trainings are interprofessional, team-based. And then we want grantees, we require that they establish and or maintain education and training programs in tribal organizations, underserved and rural primary care sites and delivery systems. This is another statutory requirement, and we call this T-TOR for short. For our reciprocal partners with the 19 to 24 cohort, they developed over 3,000 partnerships between academia, primary care, and community-based organizations. In 2024, we had a new cohort and awarded 42 awards. That's 5 years from 24 to 28. Each award is up to $1 million each for each of the 5 years. So the data is from the data I'm going to show you is from the 2019 to 2024 cohort. So what are our requirements regarding dementia training? And this happened really because of our work with NAPA Council. So we discussed things here, then we discussed them at the agency, and then we see where we can integrate this to train the workforce. So we want to take the research and have it delivered and trained to primary care providers. And then together between research, workforce development, we can influence policy. So all grantees must set aside $230,000 of their $1 million for ADRD, and other mental health issue training, delirium, anxiety, depression, substance use, and opioid use disorders, and serious mental illness. They have to train on ways to risk-reduce chronic diseases, including dementia. They have to train on early detection, diagnosis, treatment, and management of dementia. And they have to treat primary care providers on how to enroll older adults in clinical trials. Really, the first step is teaching them what's available, how to identify patients to be in clinical trials. But because if they don't know about what's there and how to enroll them, they're not going to do it because they're really busy, like everybody else. So just some data, and this is from academic year 21 through 2024. This is on academic, didactic, and clinical courses. So they trained over 2,000, no, they developed or enhanced over 2,000 clinical and didactic courses, but they have a really large reach. They trained over 402 trainees. Of that, about 189,000 were healthcare professionals, but more interesting were the patients, families, and caregivers. There are more patients, families, and caregivers than healthcare professionals, and that just speaks to the need of patients, families, and caregivers to get dementia training on how to care for their person living with dementia. And then for CE, again, nearly 2,000 courses were developed. 805 of those were approved for CE, and again, over 400,000 were trainees were reached with more patients, families, and caregivers than the healthcare workforce. And then faculty, if faculty don't know the content, they're not going to teach it. So one of the requirements of the grant is to teach faculty about Alzheimer's disease and related dementias. So faculty who were in training developed about 330 AD/ADR courses. They delivered it to over 23,000 individuals, and again, more patients, families, and caregivers than professionals. Then we have one other program, our Geriatrics Academic Career Awards program, and this program is to support the career development of junior faculty as academic geriatricians or academic specialists. So for dementia, they developed their own career development plan, but they are required as part of the grant to educate and train the healthcare workforce within the context of age-friendly framework to address dementia risk reduction. I can't see. Dementia across the disease trajectory, including training on dementia medications as they are appropriate for use, and nursing home care. We made 26 awards in 25, and they were about 92,000 each, but this year in 26, there'll be more because by statute they're required to have a cost of living allowance increase. And that's it. Thank you.
Thank you so
Oh, I
much.
just wanted to say we have 2 GWEPs in Florida since we have so many colleagues in Florida. One is at Jesse Trice Federally Qualified Health Center in Miami, and the other is at Florida State University in Tallahassee.
Yay, thank you. Thanks for sharing that.
Who do I give this to next, Helen?
Actually, CDC is going next, but they don't have slides.
Oh, okay.
Set it back up here. Oh, there are slides.
All right, thank you so much. We are going to now turn things over to the CDC. I believe Captain Fleetwood Lusto's on Zoom.
Hi, yes, can you hear me?
Yes. Yes.
Excellent, excellent, thank you. Thanks for that. I'm excited to be here today, and I'm 8 feet tall behind you if you need to turn around. It looks like on the screen there. So that is a scary rendition. It's my first time here with the group, and so I'm really excited to present the work of CDC. So many things. I'm relatively new to this area, new to this role as the acting principal deputy director, but have been in our center for about 20 years and know the work well, mainly in cardiovascular disease. And it's just amazing of how much overlap we have with our particular areas. I think I was particularly of interest as well when Dr. Bateman was talking about a lot of the work as well. I could just see so many interconnected points. But I spend about a day a week as well in a federally qualified health center locally, and it keeps me grounded, I would say, in a lot of the work that I talk about and that we do. And so I definitely appreciate that balance of being a researcher, being a manager, but also being able to be in the clinic and being able to see on a weekly basis really the patients, the struggles, the barriers, and the benefits of connecting those as well with the care and resources that we provide and that many of you provide as well. So I have had a few connection issues today, hearing people. So if there is that as well with me along the way, maybe somebody could raise their hand. I could go off camera if needed as well, if that's related to some of the connection issues. But like many of you have expressed as well, I have a personal connection with Alzheimer's. My grandmother was diagnosed and went from a very vibrant individual to one that we had trouble recognizing in a lot of ways. And so a passion of mine as well, as many of you share. So our center is the Chronic Disease Center at CDC, and it touches a lot of these areas that we've talked about today. And also the promotion of a lot of the activities related to healthy lifestyle, such as physical activity, healthy diet, and the prevention and management of hypertension and diabetes. And I really see our role as a center as one to facilitate, to support, to partner, and to lead in this area. Now, many of our subject matter experts in this area are currently on administrative leave related to reductions in force from the prior year, but our funded activities continue, and I'll take some time to review those activities and highlight some of the recent work that's been going on. And as several of the speakers have talked about today as well, this is just going to be a brief overview. There's so many activities that I've really begun to appreciate as well that are going on in this area that we support and that we partner with as well. The programs I'm going to talk about today really reflect 7 key priority areas to reduce dementia risk, to promote early assessment and diagnosis, to improve outcomes, to support caregivers, to educate the public and workforce, to drive population level data for decisions and actions, and to accelerate adoption of evidence-based strategies. So the 3 main areas that I'm going to talk about today are the public health programs to address Alzheimer's disease and related dementias, the BOLD program, where we have 43 state and local recipients of funding, also the BOLD public health centers, centers of excellence, the public health centers of excellence is how I'll describe them, and then the Healthy Brain Initiative. So I'll go into detail with each of those 3 activities, but we also have the National Partners Cooperative Agreement funded projects, which are 3 recipients that include the Association of State and Territorial Health Officials, the American Medical Association, and the National Association of Chronic Disease Directors. I will try as best I can as well to limit the number of acronyms. It is challenging along the way, but I will do it. The activities within those cooperative agreements mainly include better integration of community health workers, to provide training for healthcare workers, and to support communication and coordination activities. So the BOLD Award recipients, it's 43 state, local, territorial, and tribal recipients over a 5-year period, excuse me. And all recipients use the CDC's Healthy Brain Initiative state and local roadmap for public health and the Healthy Brain Initiative roadmap for American Indian and Alaska Native peoples as guides to expand and improve the response to Alzheimer's disease and related dementias in their jurisdictions. The main activities that occur within these funded partners are to increase awareness and understanding among the general public and healthcare providers, to address Alzheimer's disease and related dementia, topics corresponding to primary, secondary, and tertiary prevention, and to address social needs and non-medical factors that influence health. There's two main components of this particular area of funding. The first really, to me, speaks to the desire to increase capacity within state and territories related to this work. And so the component one aspect has 2 years of funding in areas where capacity building is needed. And then the remaining 3 years really focuses on the implementation of those activities. That includes about 13 awardees. Component two includes about 30 awardees and really has a jump start with those that already have capacity at that local level, but then initially funds implementation activities across that 5-year period using strategic plans that are already in place. The second activity that I'll talk about is the Healthy Brain Initiative. It also includes 2 components or 2 phases. Component one had 1 recipient to develop and update CDC's roadmap, was the Alzheimer's Association, which was recently updated in 23 and provided guidance to state, local, and tribal governments. Component B funds recipients to develop products that will effectively communicate related messages within those populations with a high burden of Alzheimer's disease. And like I said before, and many before me, there are many activities that I could focus on within this particular area. And just to hit a few, with the amazing leadership of the Alzheimer's Association, we're excited about the new 2026 cohort of 16 awardees for the Healthy Brain Initiative and Roadmap Champion Program that will strengthen local and tribal public health capacity, and the upcoming 2nd Annual Healthy Brain Initiative Summit for state health departments that will be held in June in Chicago. There's also a number of partner promotion and training activities over the next several months from partners within this group, including the International Association of Indigenous Aging, the University of Illinois in Chicago, and Us Against Alzheimer's. The third area that I'll focus on is the Public Health Centers of Excellence. And this funds 3 recipients to identify, disseminate, and to promote best practices in one of the 3 topic areas: dementia risk reduction, early detection and management, and dementia caregiving. Each of these 3 partners work specifically to improve tools and resources that support implementation of Healthy Brain Initiative strategies. There's also a substantial amount of work in this area, and just to highlight a few from our partners from the University of Minnesota and NYU Medical School, there's a number of activities supporting local communities, including educational webinars and virtual roundtables, and really serving as the bullhorn at national conferences to promote the work of the Centers of Excellence. And with the Alzheimer's Association, I'll also highlight the learning collaboratives to promote community action, where in 2026, 38 local and tribal health departments were selected to participate in the next 3 risk reduction learning collaboratives. These health departments will learn about dementia risk reduction and how to host a community convening using the toolkit from the Centers of Excellence. And lastly, I want to highlight the upcoming release of CDC's Behavioral Risk Factor Surveillance System data from 2025. It will be released in late summer or early fall of this year and will include data on caregivers and cognitive decline. In 2025, 21 states and Puerto Rico included the cognitive decline module, and 31 states included the caregiver module. These data are made publicly available and can be used to guide programs and interventions. Thank you for allowing me to give a really brief overview of CDC's activities for today, and look forward to more conversation. Thank you.
Thank you so much. I'm very familiar. I quote the Healthy Brain Initiative often and much, and I entreat anyone to take a moment and look at the HBI and the Public Health Roadmap. There's just so much great information there. So thank you so much for everything. I appreciate you being here with us. And your 8-foot self behind us.
Thank you.
I just wanted to take a moment because I think we all just need a couple minutes because we're digesting a ton of information. I just want to reiterate, we're getting our baseline. We're baking in our infrastructure here and just getting the base of everything that all the federal agencies that touch this initiative. And it should, again, reassure you that so many do and so intricately and so well. So I'm just grateful to hear. I'm learning so much. I thought I knew a lot, but there is so much more to know. So I want to again thank our federal agencies, but I just want to give us 5 minutes to just digest. We passed out some information that Dr. Bateman had on his screen that I thought, Helen and I both thought were just really incredibly helpful to look at the process by which the council works with the federal agencies and the public to engage and make some meaningful reports and advise Secretary and Congress. So look at that real quick because I think it's a really good diagram, and take a minute, grab a cup of coffee.
Produced by the U.S. Department of Health and Human Services.